Okay, I'd like to invite the panelists to the front. We're going to have, I think all of the speakers except Dr. Collins is here. And we're going to add Dr. Alex Feng, who's a renowned TCM practitioner. I always like to say he practiced before he was legal, but you didn't hear me say that, Ben. But he's been in TCM for 50 years and pioneered with Dr. Matecki the medical Qigong program at Alta Bates all the way back in 2009. So it's very exciting that it has continuously run. And of course is part of the faculty with our residency program. So if you'd all come to the front, Dr. Matecki, Dr. Bartlett, Dr. Feng, Dr. Corradino, Dr. Capizzi.
I just need to borrow your mic.
Okay.
This is a surprise. I just suddenly remembered in this room, years ago, decade ago, our medical staff, we have a yearly medical staff meeting together, all the physicians, the physicians here. Our president of the medical staff at that time announced in this room, Dr. Feng is the first licensed acupuncturist, was on Alta Bates medical staff for 100 years history. So I guess I slept a little bit last night, so my memories work.
Thank you, Amy. Okay, Donna. Dr. Matecki, you're up first. You're up first with your case presentation. Yeah. Just hit the down. You want me to just hit it?
Oh, I can do that. Oh, is Dr. Feng going to present first?
No, the case presentation should be in there.
Okay.
Let's see if it's further down. There we go.
Oh, okay.
Okay. No, go sit down. I think the intent today is that Dr. Matecki created a case that she's going to ask all the disciplines to comment briefly upon after she presents it, and then we'll open for questions.
I believe this case is from one of our board review questions, and also combine a little bit clinically with some of the patients. I think today just give everyone a flavor. So how this can, how do we practice clinically? You heard from all the experts this morning, but in clinically, how day-to-day I function. So today I function as a PCP, primary care physician, integrative medicine, we can call that too, but I just want to let you know is the role for the primary care providers. So here, this is, I will read this because we're going to discuss this case. All the expert is here. I think the expert here is a difficulty for you guys to see this case, but I just want to give you a history. So basically, this is a 78 years old woman come to the clinic with a 5-year history of a progressive cognitive declines. According to her daughter, her cognitive difficulties begins of a series of a mini stroke, characterized by acute onset of a slurred speech, difficulty ambulating, and there is a weakness involved. Those symptoms typically improved after onset, but never really resolved entirely. She recently have difficulty managing her financial affairs, completing tasks, and understanding and difficulty to understanding abstract concept. And also the recent symptoms include slowed reaction times and slowness in speak and completing task, shuffling of a gait, urinary incontinence, and a sudden involuntary laughing or crying. And the patients, the past medical history has hypertension, coronary artery disease, depression, hyperlipidemia. The current medication she is on, like lisinopril, aspirin, bupropion, and atorvastatin, which is a Lipitor. Physical exam is vital signs, fairly normal, and it's really unremarkable. So those kind of patients come to clinic, a lot of the time you really don't find significant physical abnormalities. The neurological exam revealed mild right side weakness and a right side hyperreflexia. So basically you get the jerk moment hit the knee and their knee is fling out, stronger than normal. And then also she was a little bit of difficulty when you tell her to stand up to walk. She was a little bit, had the difficult to start. But the MRR of the brain and it showed is that there's a extensive paraventricular white matter lesions and a small vessel disease involving the basal ganglia. Is anyone here, Dr. Corradino and Dr. Collins this morning's talk, right? So involve the basal ganglia. And the ventricles is normal in size. So my question here, I'm not going to test you guys the medical knowledge part. Am I right? Hit the right button. So here is the diagnosis. You can see is the cognitive impairment due to cerebral vascular disease. Sometimes you heard the term CVA, but also known as vascular neurocognitive disorders. And then, so this is a clinically fairly common. I get to see the seniors coming in with a family member, and this is one of the typical cases. Patients actually doesn't bother much with the patients, actually it's bother the families because the daughter was worried and she just not herself. And the patient's in denial. And now as a primary care, what do I do here? So I can start because my name is the first, or when Dr. Feng comes, then we will start your. So with my part, when patients are coming in this, some of the patients already have the MRI, some of the patients are already seen by neurologists, but still when they come to me, and with this kind of the complaints, I will still do my primary care part. I want to make sure this is not something I can correct it. For seniors, what is the common condition sometimes we get missed? It's a urinary tract infection. So basically, I will run some lab tests, the CBC, chemistry, and a urine analysis is one of them, especially if these patients have the complaint with the urine incontinence. So for seniors, sometimes we have to be careful with the Chinese medicine providers here, why you go through the hospital, learn all this detailed training, make sure patients work with the primary care doctor, have the infection part, everything get exam. And also sometimes I check their thyroid function because we're never involved with the memories, so vitamin B12 and vitamin, folate, and sometimes I check their vitamin D, just want to see their nutrition. I use vitamin D more like their absorption with the nutrition. If their D level is low, I would assuming sometimes they don't absorb other nutrients well. So I will run through all those details. Anything else? Sometimes it depends, I want to do x-ray or not. If the family say patients have a cough, I just, fever, there's other symptoms involved. I make sure I'm not ignore there's some underlying pneumonia infections. Okay, so this is a part as a primary care. And I will review the lab, see their sugar, diabetes, how their sugar level is, their cholesterol level is, and also their blood pressure. Some of the patients coming into the clinic, their blood pressure could be high or could be low. So I have to be very careful. The one with the low blood pressure could underlying have other infections, sepsis included. Okay, so now I'm going to pass on to my mentor, Dr. Feng, we met is when I was an intern at a Highland Hospital, and he came over to talk about acupuncture, talk about everything. I was one of the 6 residents sitting in the room getting inspired. I totally thinking, I can do this. Bring the acupuncture, which is an emperor's medicine, to every Americans don't have to be the emperor, get experience in this medicine. 20 years later, I realized what a journey, huh, Dr. Feng? That was yours.
Thank you, boss. So could I have this slide again? Yeah, I want the presentation. I want the case. So just from a different perspective, okay? I do TCM. This person's 78 years old. So as we heard before, if you're elderly, chances are more complicated, so don't get old. Or as you get old, learn to preserve yourself well. So number 1, age. Number 2, female. Number 3, 5 years history of cognitive decline. So it's been around for a while. It isn't new. So I'm sure she's already seen her primary and probably a neurologist, as she should. Her daughter, cognitive mini stroke. I'm not sure this is a blood, is a clot or a bleed. So I have to find that out and see what the result of that is, because it manifests differently. Where am I? I said slurred speech, that happens with brain stuff. Difficult ambulatory, difficult movement weakness, all happens with a mini stroke, possibly other things. Typically, one said never resolved. Yeah. Recently had difficulty managing her financial affairs, for sure. Completing tasks, understanding, blah, 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 blah. This is all the cognitive stuff. Slow reaction to, okay, this is all the same thing. Slow speech, slurring, shuffling gaits. So you have to look at possibly shuffling gaits, maybe some other kinds of like Parkinson's that's involved. Or, look into dementia. Those are things you look into. Urinary tract incontinence, you want to do the urine test and see whether there's an infection for sure, as Dr. Matecki mentioned. Involuntary laughter and crying. In terms of Chinese medicine, that is a heart issue. So heart 3, so high, specific points, regulates that sort of manic depressive behavior. So in terms of traditional Chinese medicine, there is a way to look at that particular symptom and say, well, possibly is a issue of heart function. But heart function in terms of Chinese medicine, TCM, is a little bit different than Western perspective of the heart. So it includes spiritual component, emotional component, physical component, blood flow, so on and so forth. So it's a little bit different. If you study traditional Chinese medicine, you'll have a sort of a broader view of when I say heart, what does it mean? Laughing and crying. Okay, patient, hypertension. Hypertension, oftentimes we say there's some liver involvement. You're uptight. So we might look at the pulse, which isn't presented here. We may look at the tongue. The pulse tells you different things, as those who study TCM will know. It's very subjective, but not all of us are like great musicians. And if you are, you can take a pulse and read. We say, 像, meaning the presentation, the view of the pulse, but also the sound of the pulse. Those of you who... You have to be in vision of camera. Alex, come over right in the middle, please. I don't want to put my butt in front of these people, so I stand like this. Well, I want to share a story with you. I have a teacher by the name of Guru Mai. I can't stand in front of you like this. This is rude. No. I can't. I'll do that. Thank you. So I was in New York, and there's like 5,000 people in the audience. And my teacher talked about death. So I turned around. My teacher's sitting over there. I talked to them, and I turned and talked to the audience. about death and the experience of death in sort of yogic perspective. And she looked at me and looked at the audience of 5,000 people. She said, aha, turn your back against your teacher. Great lesson. So where was I? The heart, the liver. So the liver. So depression is probably a liver issue. So we do look at the liver. We do look at liver. We do look at kidney function, because kidney function affects the brain. So in terms of traditional Chinese medicine, we look at the kidney, bone marrow, urinary function, reproductive function, function of the brain. All that belongs to the kidney, including the adrenal gland. So traditional Chinese medicine has a different perspective. It's all good, it's just different. Where am I? Physical exam, everything is cool. Unremarkable. Neurological, it's been decided she has some problems, and MRI shows she has some problems. Can these problems be resolved in a white matter, lesion? Next slides, please. Yeah, I need my slides now. So, that's me. TCM. TCM includes many things, by the way. So not just acupuncture. TCM includes spiritual, meditative, massage, music, guasa, herbal medicine, diet. There's 4 things that we do for good health. And our perspective of good health in traditional Chinese medicine. One is that how you bring it in, diet, emotion, thought, form, so on and so forth. Number 2, how you eliminate. Those 2 things you need to have. What you bring in, how you let it go. Number 2, you need to move. Just move. My father's favorite exercises. When I tell him to do exercise, I am, he says. Just move. So Tai Chi, Qigong is really, really good. As Dr. Matecki promoted the Qigong practice at the Cancer Center for cancer patients, because they don't have the energy to run around and play ping pong, tennis, basketball. But you need to move. So Qigong is one of the easiest way to move in place without doing much and sweat. So Tai Chi is the same thing for balance. It's not here anymore. Yeah. Tai Chi for balance, for gates. So those are some of the things we do. And music. Dr. Matecki is a visionary. Sound, in traditional Chinese medicine, as well as Qigong practice, there's what we call 六字诀. 六字诀, 6 sound that relates to the organ. When you're upset, you make certain sound. When you're angry, you make certain sound. When you're sad, you make certain sound. When you're happy, you make certain sound. Those sounds are healing sounds. And we use that for healing. When you're not feeling well, you listen to some kind of music, whether it's classical, jazz, Afro-American, Cuban, whatever. It makes you feel good. Sound healing. So many components. Dr. Lin Shin, who I really respect, is a physician from Irvine University, Southern California. And he's done research on Qigong, or Qi. What is Qi? He uses 3 determinants. Number 1, blood flow. Number 2, electrical output. He designed some sort of machine to measure that. And number 3, temperature. So you use those 3 to determine, does a person have Qi or no Qi? So he also discovered that slow, repetitive movement can bring about a healthy state of those 3 things: blood flow, electrical output, and warmth. So, but marathon, triathlon, niet, doesn't do that for you. So the suggestion is slow, repetitive, easy movement that is nurturing. He did the same research with cats. If the cat is grooming themselves, some of that chemical and electrical system in the body changes to what some people call homeostasis, healthy state. So in traditional Chinese medicine, of course, we'll look at Jing, Qi, Shen. Shen is spirit. And how do we determine Shen? You look at the eyes. And what are you looking for? You're looking for interest. They have no interest? Difficult case. Very difficult case. Jing, if you swirl your mouth, can you collect some saliva? Jing is like essence, the clear essence of your body, oftentimes considered the fluid of your body. Our body is 85% fluid, of all kinds of fluid. Synovial fluid, interstitial fluid, lymphatic, blah, 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 blah. So, fluid. So you look at, do you have fluid in the body? Are you moist? Are you dry? And you look at qi. Some of you have been in my class before. So all I ask is for you to do this. Ha! 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 1, 2, 3, go. Again. If you can do that, you have qi. You can't do that, you go to the hospital, people who are dying, ask them to do that. Not possible. You have to have qi, energy. So those are things that we look at to get an assessment of the individual. Qi is written traditionally in 3 different forms. The last one on the right is air. Air. You need air. The one in the middle, you see the bottom character, radical, is rice. The top character represents vapor or air. So it's the relationship between substantial and insubstantial. What's real, what is above reality. So food is rice, but the food that gives you the energy with air combined together, you have now a relationship of symbiotic relationship of this and that. Makes energy. And energy, the last character, energy, there's different, all kinds of energy, by the way, you know, the organ energy, meridian energy, emotional energy, spiritual energy, so on and so forth. So it's a big word like love. The third character, or the first character on the extreme left, means no desire. Why would classical Chinese doctors use that word to describe energy? No desire. If you have no desire, maybe you have energy. So,
You have just a minute left. So you have
I have 2 minutes? Oh, good. In that case, all this is extra.
Relationship, I said 1 and he heard 2. Keep your
That's the basis of our relationship.
I love it. So I want everybody to do this. Brain health. Reverse. Next finger. Next finger. Next finger. Go back. Brain health. Second exercise for brain health. I have many of those. Touch your nose, cross your arm, touch your ear. When I clap my hand, switch. Uno más. Outstanding. Brain health. Both hands goes forward.
Oh, that's the hard one.
Both hands goes backwards. One hand goes forward, one hand goes backwards. When I clap my hand, switch. One hand goes backwards, one hand goes forward. One hand goes backwards, one hand goes forward, one hand goes forward.
Dr. Feng.
Brain health. next. No, I can just look at the slides. Let's do the slides very quickly.
I don't think we have time.
Okay, we quit.
Okay, so let's go.
Microphone?
Oh, I'm sorry, I forgot to bring the mic back.
That's your relationship.
I like reminders. Okay, I'm going to hand the mic to Dr. Capizzi to comment on the. There we go.
Hello. Is this work? Is this okay? Yes. Okay. Okay. Great. So it's okay to sit, or you want me to stand? Oh, stand. Okay.
2,000 people watching right here.
Thank you to all the 2,000 people. Thank you for participating and your attention, and to the people who are here. So I presented earlier about brain health and traumatic brain injury, prognosis, and resilience. And from the viewpoint of a rehab physician in this particular case, this is a common case for me too. And most of the time I'm in the hospital, sometimes I'm in the clinic. So the rehab systems, we're trying to maximize function. So things I'm thinking about are bowel and bladder function, sleep function, mood, thinking about the nutrition, thinking about the tone of the muscles. So I'm also thinking about, I love that Dr. Matecki pointed this out, confounders that we may be missing. And so the imaging is pretty convincing with this MRI. Sometimes patients fool you. And in this case, I might consider consulting with my neurology and neurosurgery colleagues about doing a large volume lumbar puncture to assess for normal pressure hydrocephalus. So if that is playing a role in the incontinence and the gait challenges and the mood challenges and cognitive dysfunction, it may not necessarily cure everything, but it may improve the situation, right? So I might think about that for this case. Think about things that might be contributing in a negative way that are already going on. So this patient is on bupropion. That's a pretty common antidepressant, and often a good antidepressant. For some patients, and particularly post-stroke, it can be a little too activating. And so in this case, a patient who's exhibiting signs of pseudobulbar affect, or what we also call as rehab docs, emotional incontinence, we might consider switching off of bupropion and trying sertraline or Zoloft, a different antidepressant, to try and cool down some of that heightened response that they're getting, the crying and the laughing that seem to be uncontrollable. For the gait challenges, I think that this patient would benefit from physical and occupational therapy. I work really closely with therapists, so I would engage them, whether it's on the inpatient rehab unit or if it was in the clinic. And they may need home health because they may be homebound, so home therapy may be more appropriate than therapy in the clinic. I think that would also help with the tone issues. It sounds like this patient is hyperreflexic and maybe developing spasticity. And there's a lot of interventions we have for spasticity in someone who's elderly, and we're worried about side effects from pills, like baclofen, that might sedate the patient too much and cause more issues with incontinence and constipation. I may use botulinum toxin, so I might do injections for this patient to try and relax the muscles in ways that would allow her to move more efficiently. We talked earlier with Dr. Collins about baclofen pumps. That could be appropriate in her case too, depending. I think with the urinary incontinence, I love the idea to get a urinalysis. A lot of my patients get on a timed void program where I teach patients and families, try getting up every 2 hours and just go to the bathroom, no matter what, no matter if you feel like you need to go or not, and try and train yourself to have those continent episodes. The other thing you can do is space out your fluids. So you should be drinking, typical person, about 8 cups of water a day, but space that out so you're not just dehydrated all day and then drinking a bunch of water and then having incontinence happen. Keeps you up at night, perhaps, for if you're not spacing out your fluids appropriately. So those are the main things that I'm thinking of in this case. There's obviously many more things that we could offer in the field of rehab medicine, but any questions about that approach?
If you have questions, there is a microphone over here. If you don't mind, go to the microphone for any questions.
Okay, maybe after we hear everybody, Dr. Capizzi, we'll have questions. Dr. Corradino.
Well, hello, and thank you again. So, I'm going to take a look at this as I would if this came into my office. I don't have an integrated center like this, but I definitely refer out and I work with other physicians. So everything everyone said, I would just go right along with for sure, making sure they have a primary, a neurologist. But now looking at the case, what do we see? 78, 5-year of the cognitive decline, mini strokes, speech. What side of the brain is that? Left. Difficulty implementing financial affairs. What lateralization of the brain is that? Left. Right side weakness, left side brain. So I'm going to start looking at the left side of her brain, maybe also see if there was, that's where the stroke was, basal ganglia was bilateral, so maybe there was an aspect to the left side that got hit more. The shuffling of the gait, the incontinence, those two, obviously shuffling the gait, I'd want to just look at that and, you know, is it basal ganglia involvement possibly? It could be also just from the mini strokes, left side, motor cortex, frontal lobe, in urinary continence. So what I'm going to do now, a couple things. I'm going to take a step back and look at all this and then see if I can put a prescription together in neuropuncture that will address as much of this as possible, right? Or can I break it up into maybe 2 or 3 prescriptions and see the patient 3 times a week or twice a week for 4 weeks and then put those prescriptions throughout the treatment plan. So what I would do for the medications, I have hypertension. We have great prescriptions for hypertension that come from UC Irvine, actually research that absolutely is very effective, which is amazing because it's peripheral nerve stimulation that actually targets the RAS system, the renin-aldosterone and angiotensin system. So we might be able to help out with some of those areas of medications if we needed to. Definitely with the depression as well. We got amazing prescriptions for depression, for a lot of that that'll help the brain. Same thing with statins as well. You know, we have to look at that because what's the brain made of? Yes, so we don't want to keep that cholesterol too low, right? We want to make sure they're getting their fatty acids, making sure they're getting, I would probably very much encourage a ketogenic diet if I could. You know, what's the first thing I do with ketogenic diets? I don't tell my patients, start counting your ketones. It gets way too confusing. Just do something simple. I did the same thing. My cardiologist told me this. Don't put sugar in your mouth. Just start with that. So I went home and threw all my sugar out of my house. I don't drink intake and no sugar anymore. No more cannolis unless it's a really special holiday. But I don't do that anymore because I want to prevent cardiovascular disease. And apoprotein happens to be, that's one of the reasons why that happens. Okay, so prescription-wise now. Okay, so now let's look at that cognitive decline. What prescriptions do we have in neuropuncture? Now we know based on functional MRI and research that we can target basal ganglia, right side cortical structures, and maybe some other subcortical structures for the depression. Absolutely we do. So I could throw out a couple of prescriptions just real quick. We talked about one that was in the Parkinson's. So we could do 14 and do 20 at 100 hertz, and that's gonna modulate the basal ganglia. There's another really neat prescription I'm not gonna tell because it's risky, but you have to learn it from me in workshops. But it's a really intense prescription that we know is targeting the basal ganglia and really hits the brain. So there's something there too that we can mix in there. And then again, that left side brain, I would start looking at Broca's and Wernicke's and see what aspect is damaged and start needling over those regions. And it's important we know the anatomical regions of the brain in reference to the skull. You know, with acupuncture, sometimes we get confused that the homunculus, right, of the somatosensory region and the motor cortex, what's on top? At Pai Hui. It's not the foot, it's the knee. So we have to know our regions and our structures, where they are, where Broca's is, where Wernicke's is, where's the auditory center, right? Where's vision, where's balance, cerebellum. So for this, yeah, I do left side, and I would probably start threading some needles in those areas. We have a technique in neuropuncture on that trinity. The last one on the electrical techniques was DCEA and EAMS. DCEA is deep cranial electrical acupuncture. It's a technique actually I came across on my own just looking at it and looking at physics. When you attach a clip to a needle, that simply through physics creates an electromagnetic field, right? So when I put a needle into Pai Hui or Yin Tong and I clip a needle, boom, you got a little electromagnetic field. And that's DCEA. And what I do in neuropuncture is we'll group the needles together. So maybe we'll put maybe like 20 needles down that motor cortex and then stem it And now we have a nice electromagnetic field that's hitting those cortical structures. And that's really important. Actually, be left side. And what do we do when she does that? Move your right arm. Start moving it, because when we stimulate here with electroacupuncture, what are we not doing? Even if we do peripheral points, I teach this also with our stroke patients. You do peripheral points on stroke patients and they feel it, you're not rehabilitating them, right? Because that's sensory. We have to fire their cortical, their efferent tracts, which is a cortical spinal tracts that only fires downward. So we have to get them to move while we're stimulating the cortical structure, so we make that connection. So that's kind of what I would approach. And then definitely look at nootropics, for sure. Dan Shen actually crosses the blood-brain barrier, helps clean out amyloid plaque and stuff. So I'd put things like that together. And then definitely work with all you.
Thank you. If you'd hand the mic to Dr. Xiaodong Feng.
All right. So, I try to link it with the case I presented about GBM. It seems like it's hard. So I would like just to interpret from perspective as a pharmacist. Look at the medication, I feel like definitely when we talk about patient treatment, it's not just the medication prescribed by physicians, also could be alternative medicine, herbal medicine, or supplement. For example, this patient, look at the history, it's very possible patient could try green tea, could even try ginkgo, like for cognition, for memory. But all this, they have drug-drug interaction. For example, green tea, ginkgo, actually, they could potentially increase bleeding risk. And also, when you look at we don't have the lab right now, but all the prescription medication potentially also influence the lab. For example, lisinopril, you're going to check your potassium level. And if you already hyperkalemia, definitely lisinopril, is not a medication you want to be on, or you have to monitor, adjust. And aspirin, if patient, they have the mini stroke, is this mini stroke caused by bleeding or clotting? Aspirin will increase the risk of bleeding. And so you have to evaluate the risk. And atorvastatin, because of the treatment for hyperlipidemia, but also we know atorvastatin can affect the liver function of the LFT enzyme, like ALT, AST, bilirubin. And atorvastatin, believe it or not, also affects the muscle. So, this patient already with the muscle weakness. So should we evaluate all this together? So it's a very holistic, but at the same time, for me as a pharmacist, I want to say, okay, this is a 7 to 8-year-old patient with many years of history of hypertension, hyperlipidemia, or coronary artery disease. Is this medication, very simple medication, got all this control? To be honest, I have doubt. I just feel like that's why when we evaluate the medication, it's not just a side effect, drug-drug interaction, also did we achieve the therapeutic goal? It's a joint effort, it's a team effort with the PCP, with all the healthcare team. And definitely, medication will affect the lab. For this patient, I will check the renal function. Lisinopril will definitely affect the renal function. And based on all the condition, so this actually will affect our decision, what's the best medication to control patient's hypertension. And atorvastatin, as I already mentioned, it started with the liver function. Actually, liver function for traditional Chinese medicine, Dr. Feng, you are expert. Liver function and renal function, they are always connected. Actually, now it's proved by Western medicine, because many years ago, when I was in pharmacy school, atorvastatin, they only talk about liver toxicity. So now they start to say, oh, it might also affect renal function, because they are always linked together. And when you affect renal function, also autotoxicity, the ear function start to be affected. You can see all the connection with the traditional Chinese medicine, because we know I feel like all of a sudden I know so much about the traditional Chinese medicine because I learned from the team, because renal is connected with the ear. So I feel like this is a wonderful case, even though it has nothing to do with GBM. I just feel like by looking at this, there are a lot of follow-up and investigation. I look forward to see the lab, so see how much we can intervene as a pharmacist. Thank you.
Thank you. Okay, Dr. Bartlett.
All right, I am completely unqualified to be here at the ground rounds or whatever you call this. Like actually, over the last 30 years working in this nutrition area, I get a ton of questions like this. Hey, Dr. Bartlett. And I'm like, I'm not a real doctor, right? So I'd have to look at this and say, is this my mom? Like, she's about this age, maybe a little older, right? And I say, well, for all of these things, you need to go see a doctor. And man, I tell you, I know where the dream team is right here. But there are some things that kind of stand out to me a little bit, and it's what I mentioned before, right? I think as physicians, you guys have amazing approaches, and you can see how different they all are, and how if you're working together, that would be awesome. What I see here is like, okay, if this is my mom, I'm saying, okay, you need to take care of some of these things. I can see some of the neurological stuff going. But I would zero in on a couple of things. Like, if I know her, if she's my mom, I know who's looking after her. I know how she's eating. I know if she's getting a good diet or if she's hardly eating. When I look at this, I say, well, why do we eat? Well, there are micronutrients in the food that we eat. What are those micronutrients, the vitamins, the minerals? What are they for? Like, does it matter that they're going down as you age? Well, it actually does, because micronutrients are cofactors for the enzymes that run your entire metabolism, right? Everything is about catalyzing these reactions of life that will not happen without those micronutrient supports, right? They're all, just imagine the enzymes are like little Pac-Men and they have no teeth. The cofactors are actually in those active sites of the enzymes that help catalyze the reaction. You don't get vitamin C, you don't get collagen production, and a lot of other things, right? So you have to, I would say, okay, let's look at, like, are you living by yourself? Have you got someone to cook for you? Are you eating? And then I would sort of focus again on, like I mentioned before, muscle and protein. Are you getting enough protein? Because this is really common in the elderly, that you get age-related sarcopenia. So, and I've mentioned before, that's kind of your prehabilitation and also maybe in this case your rehabilitation. And then I'm glad you mentioned cholesterol, right? It's really important for our brains. And I know that, I've never, because I'm not a qualified physician, right? I've never said to someone, hey, your doctor's got you on a HMG-CoA reductase inhibitor, you should stop that. I mean, I would never say that, but it's my understanding that cholesterol itself is not atherogenic. It's only oxidized cholesterol that's atherogenic. So maybe stay on the statin, maybe not, but at least make sure that whoever's cooking for you or you're cooking, you're getting color in your diet, because it's full of antioxidants, especially the lipid-soluble antioxidants like the tocopherols are actually going to help protect LDL from oxidation and sort of help with at least that part of it. And I love also what you said about the side effects of these statins, because they cause rhabdomyolysis, right? So that kind of muscle soreness. I remember when the doctor put my mum on a statin, she complained of muscle soreness. So I'm glad her doctor paid attention. And the other thing is, when you inhibit HMG-CoA reductase, you inhibit the downstream production of CoQ10, right? Which is really important for energy production. So if you have to stay on it, at least supplement with a CoQ10. So yeah, like I said, I'm not a doctor, but there's a few things that even I can observe there and hopefully help.
Thank you. So I think we've just had a real life experience here of what integrative medicine looks like and why it would make sense to bring it to the whole world. Would you like to sum up, and then we can open it up for Q&A?
Yes. So you can see this is how, as a primary care doctor, right? You don't have to know anything or know everything. You just need to bring the expert in the group. I do consult a lot because I'm like those kind of physician, I want to sleep at night. So did I miss anything? So I just want to bring the experts always into my practice. So I refer patients to the subspecialty, different specialties constantly. And one part I just want to add is clinically, many of the patients, medication non-compliance is big. So this is one, especially with this patients, is a mini strokes. So that's how triggered for me to think maybe the patients are not taking the blood pressure medicine, not adhere to the blood pressure medication because of the side effect. Weakness is a big one. So whenever patients have the blood pressure become normal. When they high, they become normal, they don't like it. They feel like my energy is low, I don't want it, so they quit. So this is a very dangerous, especially in Asian, Chinese population. The number one mortality rate actually is a stroke, not a cancer or cardiac. Big reasons the medication, one of the reasons the medication non-compliance. I just wanted in here. Thank you. And thanks to all the experts in the room. Thank you.
Okay, I'm going to open for questions. If you go to the mic right here. Dr. Marshall?
It's a little too high for me. Can you hear me? Well, as a pharmacist turned TCM practitioner, I wanted to add on to Dr. Feng's comments on the drug interactions and stuff. Oftentimes when elderly patients, when they've been taking medication for a long time, for 20 years, and the dosage never changed, and you know what happens when people get older, the kidney function goes down, liver function goes down, so they cannot metabolize the drugs, they cannot excrete the drugs. But this case, it did not say the dosage, it did not say how long the patient is taking the medication, because oftentimes when I do the history, I always ask when, how long. So I had a patient, a good friend, a patient of mine, she called me one time and said, oh, I've been so tired. And then I said, what have you done lately? She said, nothing. And that was my cue because I've known her for 20 years and she had, the same medication. And I know that she's been taking the same medication for 20 years. The dosage never changed. So I told her to call her doctor and have the medication changed. And then she called me back and said, oh, I felt so much better. So I think that in taking history, I think we need to ask how long they've been taking it and if the dosage is still appropriate when they're taking at 60 years old versus they're taking at 78, 80 years old. And I think at this point, I have a suspicion that the medication she's taking all have similar side effects that contribute to her, cognitive functions. She's not able to, she feels dizzy, tired, and all that, and then you give her something else, and then the problem just compounded itself. That's my comment. Thank you.
Thank you. And Dr. Morales.
Thank you. I have a question for the panel about this case, and I just wondered if anybody has thought about this, the concept of sleep apnea possibly being a risk factor here with this person. I know that sleep apnea that's not treated can increase your risk of stroke, but I don't know about all this other stuff, so I'm just interested in comments.
Oh, that's a very good point.
So yeah, sleep apnea definitely is extremely stressful for the heart and the cardiac system. Wow, it is, very disruptive. Though I think she would have had a diagnosis if she had that. I guess you could also definitely do with a history, ask her family members or anyone that she might be sleeping with if she has had that history of and waking up at night or having that type of instance. But yeah, I think there was someone who would have been written though. But yeah, anyone else?
I recently had the sleep apnea test done. It was one of the most awful tests. Whoever designed it is like, you're not going to make me go to sleep the way you did this, How could you measure anything? So anyway, that's my 2 cents, my personal experience. Sleep, you can't do sleep. Sleep has to do you. Second thing, we also ask the question, when you wake up, are you refreshed? So some children, they lay down 1 hour, they play for 3 hours. They lay down for 20 minutes, they play for another 5 hours. Well, we can't do that. But maybe it's the quality of sleep, not necessarily the hours you sleep. So I always ask the question, how long do you sleep? And do you wake up refreshed? So that tells me a little bit more information.
Are there any questions from YouTube or your podcast, Bill? Okay, go ahead, Dorina.
Okay. I'm not a doctor, but I've been a patient trying to navigate the system. And we just heard 6 opinions that build on each other. But my question is, as a patient, what is the avenue to enter the system and get all of this wisdom, ideally, in order to get the diagnosis right?
Key question of the day. Why don't you pass the mic down through everybody, Amy? You can start.
Yeah, no, that's really a good question, because sometimes as a primary care, I have patients come in all the time, I ask that, where do I start? You know, so all this is so complicated. So it is true, but I would say always get back to your primary care. You can hunt them down. Where's my neurology referral? Where's my, rehab, physical therapy? So I think we are the gatekeeper, but also we are the one ultimately respond, for the care. I can just pass on. Yes, rehab.
Okay, thank you. So when I have interns with me, I tell them that the insurance is the 5th vital sign to pay attention to. And when I print out my list of patients for the day, I include the payer, the insurance, because that will dictate some of how you navigate the system, to your point of how do you access these people. If you have healthcare, like a managed plan, an HMO plan, all your referrals need to come from your primary care. If you have a PPO plan, then you are in more of the driver's seat in terms of, you could self-refer in some cases, or you can have your specialist refer for you. So knowing your insurance and how it works or doesn't work is valuable. If you're not able to advocate for yourself, designate someone to do that for you. Because one of the challenges we experience as healthcare professionals is that a lot of, we may put in a referral, but then there are these big healthcare systems that don't function as well as we want, so referrals can get lost. And if you are the patient or the advocate for the patient, the power of attorney, say, call your the neurologist office and say, look, my primary care center referral, I want to know the status. Like really taking charge and ownership of what you need, of course, with the guidance of your clinicians, will help you get there faster. So I tell that to my patients and families. The other thing is, as healthcare professionals, network. So this is an opportunity to network. I take opportunities to network at different conferences with my colleagues in the doctor's lounge. Who are you? What do you do? Oh, great. And then I think, oh, this person was had great bedside manner. They seem really knowledgeable. That's someone I could send my patient to who has X condition. So networking is so valuable. Keeping your Rolodex healthy is so valuable to your patients and to you. And you'll also get referrals in kind. So those are my points. Okay.
Good.
Excellent.
I guess my perspective is as a patient, not as a doctor. And I think that's a really great question. And for me, it boils down to, my wife and I talk about this all the time. Your health is something that you have to take responsibility for. And I feel like sometimes when you go to a physician, you feel like you're handing the problem over to them, and do you completely rely on your physician? Sometimes it works. Like we have in Australia, a very trusted family physician that we've known for years, and we just really have a great relationship. I think that's hard these days. Like, a doctor retires, suddenly you've got a new doctor. There was an example recently. I had an example in my head of my family situation. I love what you said about an advocate, because my father is 84 and has a melanoma, but he's also hard of hearing. And it is unbelievably difficult to navigate like all of the appointments, and then, basically me or one of my siblings has to go to every appointment. I know you're not in that situation yet, but man, we have to think about it as we age. Like, I have to actually sort of write notes and text them to my dad and text them to my family members and say, here's where he's at, here's where his next appointment is. But again, sort of boiling down to you're responsible for your own health, and if you don't like what you're hearing, if you're not completely comfortable, don't be afraid to ask the question. Sometimes it falls on, like, sometimes the doctors don't like that. My experience is you ask and you say, but I thought, and they say, like, you know, like, oh, you've been going to Google, haven't you, right? So, you know, that was the case when we had children. My wife and I were just like, well, we read all the literature, and for every intervention, there's a side effect. And we were having twins, and the doc said, well, you know, it looks like a cesarean, and you should do this, and you should, and everyone in America does a, what do you call it, the spinal tap, the epidural. And we were like, you know, we don't want to go that route. We feel like we're healthy, and both babies are head down. So, like, didn't we have to struggle a lot with, like, here's our plan. It's in our hands. We did hypnobirthing. I know that sounds kind of weird to you, but it worked brilliantly. But we had to talk to the doctors. We had to put the plan on the door. We had to ask them to dim the lights. We had to take control. And I feel like that was a microcosm of health in general. Like, birth should be sort of a natural, wonderful thing, and it still is a lot of intervention. And if you're uncomfortable with it, then don't be afraid to ask and even seek a second opinion.
Definitely. Okay, so that was a great lineup for me. That was perfect what I was going to say, the same exact thing. So I have three little things to make. One was at the time when I was creating neuropuncture, about 20 years ago, I was working at a clinic on campus of Palomar Hospital, the new pavilion in Southern California. We had the Integrated Medical Center. It was ours down there that we contracted with the hospital. And then I was working there Monday, Wednesday, Friday. And then Tuesday, Thursday, Saturday, and Monday night, I went to a very special place. You might have heard of it, called the Golden Door. And I treated them. I was a residence practitioner. This is like the 1% goes there. And I would meet with them every day, or every Monday. I'd go there after the hospital, have dinner with them, and then I'd have a talk with them. I'd talk to them about Chinese medicine and try to get them to understand about what we do so they could influence the world. They're very, very influential people. And when I had privates with them, I told them exactly what he says. I say, hey, so you have a family lawyer, right? Yes, right? You have a family accountant, right? Yes, right? You have a financial guy in your family, right? Yes. You have a great medical doctor, that's a family member, right? Yeah. Get a good naturopath or good natural medicine doctor as well on your team. And you have to take responsibility for your health. Absolutely. I think that is the most quintessential thing. And like he said, if the doctor isn't really with that on you, pick another doctor. And on that note, health coordinator. At the hospital, that's what we had. That was a big part of the integrated program. We had a health coordinator that talked to every patient, and they helped them through the entire process. So health coordinators are good. Take responsibility for your own. And then the last thing is for patients, I would do this in my clinic and make sure all of my practitioners did this. Refer to doctors, establish relationships, call a doctor, tell them you're working with one of your patients. I'm working on this. I love to always say, and I tell my practitioners, tell them you're practicing the neuroscience acupuncture system, so they're not, they can maybe grasp that understanding a little bit more and make a connection with a good doctor. And that's my introduction. I don't talk about me. I don't want you referring me patients. I need a really good endocrinologist. I hear you're awesome. Can I refer you cases? Great. Then you start to make a team for ourselves as practitioners that we can refer to, that we trust, so when the patient comes to us, we have a team we can work with. And this team obviously is amazing, right? And if we were all working under one roof, that would be an amazing institution. But I think those three things are good. Definitely take responsibility for all of your healths. I mean, I'm a huge advocate of that. I was born with a heart condition. I'm very ketogenic. I've studied Brazilian Jiu-Jitsu, and I have not stopped training my entire life. And I'm making sure I am not going to get diabetic. That's my control, right? I do not want to get hypertension. I do not want to get high cholesterol, and that is my control. So I'm going to live my life to make sure those things don't happen, because I don't want to get sick because it's just not, it's very kind of fractured a little bit right now. Okay, cool. Thanks.
Thank you. What was the question? How do you get involved in the system? Well, it's exactly what they said. You need to have a team. You need to have people working for you. You need to have primary physician. You need to have endocrinologists who can take care of you. As a neurosurgeon, an orthopedic, you need to have a priest, you need to have a financial guidance. You need a team of people that can take care of you. So how do you find that? You look for Dr. Matecki. Pretty much. What do you think? The doctor talked about advocacy. Yes, you need advocate. Who are your advocate? We are your advocate. Who are the advocate? You are the advocate. It's through your word of mouth, your connection with each other, and connection with people who are interested in integrative medicine. Because this is what this is about, integrative medicine. So give your support, find your team, get your advocate, know the people who are taking care of you, don't like them, fire them, get another one. But create a team for yourself. And verbally pass the information about what you experienced here today, about this program that Dr. Matecki created or supports. And there's lots of these kinds of programs around. You just have to look. And don't be shy. Financially support. Why not? If you got $1, pay $1. If you got $5, pay $5. If you got 2,000, 3,000, which some people have in this room, support this program. Financial health is just as important as all the other health.
So I would recommend, try to make a good friend with a pharmacist who knows Dr. Matecki, okay? So why I said that, because pharmacist is the most accessible healthcare member, and it's available 24/7. And also there's a gatekeeper can basically talk to you and help you to manage the emotion. Look at this patient. I feel like this patient must feel lonely, and with depression and even with suicidal. So, it will be nice to talk to a pharmacist and basically check the medication and see everything is under management. And at the same time, if there's any special condition, need to be referred and prioritize. And even for insurance, pharmacist is the expert for insurance. Basically get a holistic recommendation, because for physician, right now we have big shortage of primary care physician. It will take weeks or months to make an appointment. But first reach out to, don't find an excuse, oh, I'm waiting for my appointment. Go to your pharmacy, go to a good one, okay? So definitely set up the relationship and start to kind of come up a strategy, look at your medication, check your lab, and refer to your primary care physician. Sometimes with the evidence provided by pharmacists, I'm sure you will get a little bit of priority. Thank you.
Thank you, that was great. As a nurse and a health advocate for many members in my family and my extended family, I have 2 points I'd like to make. The first is that as a patient, you own your data and your information. You really need to think about what you've heard today. The assessment part, where does that come from? Who gives the story? Is it the person that's forgetful? Or is it the person that doesn't want the doctor to think they're really sick? And does it change over time? And the practitioner doesn't know, the patient doesn't remember. And so then you get medicine based on something that actually doesn't reflect the true condition. I noticed, my sister's been quite ill lately, and I noticed in her health history that my mother died of uterine cancer. No, she didn't. But that snuck in her chart somewhere, and it stayed, and they did make some decisions on her biomarkers based on that. So you have to own your own data and make sure that it's accurate. The best way to do that, and this is my second tip, use the patient portal that your doctor and your system provides. Monitor that thing and use it. I've been monitoring some hypertension and other things. I send them into the patient portal. And I say, I'm a nurse, so I can say, I'm concerned about continuing the antihypertensive at this level, given what the blood pressure is doing and what my family member is reporting. Because, as everyone's pointing out, the doctor can't see you every day or every time a new symptom comes up. But I have found the patient portals to be extremely effective. They get good responses, particularly in the Sutter system. People get back to you the same day or within 24 hours, and they're right on the spot. And also in relationship to that, many of us cross systems. And now you're able to link your patient portals so that UCSF can talk to Sutter, can talk to Stanford, and they're all looking at your same labs, your same doctor visits. That's an incredible thing. When I was a young public health student, we all thought there would be a universal health record in our future. We're still not there, but we have the edges of it. But unfortunately, it does take the patient's participation, to make all of that work, to monitor it and to use it effectively. Okay, other questions? Observations, comments about the conference? I'll open the floor. Donna. Let Donna talk, and then we'll go to Dr. Zhang.
As a peer nurse, that's part of the clinical team too. And I think patients, reach out to one of the nurses in the clinic. I take that very seriously. And if a patient can't get a hold of a doctor, it's not a criticism of the doctor. It's just like, hey, this is going on. And then I can be a conduit, and I'm working with a doctor. So I know when they're going in their office, I know when they're in the hallway, and sometimes I can help communicate that information more timely and or really try to respectfully convey the concern that's being presented to me. Because that's a huge part of it. If it's a family member or a patient, and I can tell this is really on their mind, I take that pretty seriously. So don't, these are wonderful professionals up here, but don't forget about the nurse, because we're here to help you as well.
Thank you, Donna. Okay, Dr. Zhang.
Well, I don't have a question. I just a little bit comment. It's a very good case because in your practice, it's very common. And then you think about this case, very simple way to summarize that is elderly female have the prolonged time, basically dementia, the cognitive function decline, and then now have the acute situation, right? A chronic, acute. This is the key. So when in your office, doesn't matter you are primary care physician like me or acupuncture, when the patient coming to you, you don't want to think it directly, think it, this is A or B or whatever. Yeah, you collect the data, carefully ask the history, right? Get your data together, and then you do analyze. So this is like I think Dr. Matecki actually mentioned that. Don't think about one thing, think of the big picture. What is the patient's real problem? Try to get the right diagnosis first before you put a needle in a patient, right? And then this is number one. Number two, always think about a common thing, is go first. Yeah, like this kind of patient, you can think about a very big picture. You got a lot of things you can cause that. The chronic situation, you have the multiple mini stroke, now have the acute change. You need to think about a stroke, right? Yeah, but most likely, people have a stroke, they're not coming to your office, most likely. So you have to, if you wanted me to gambling, to guess what is it, I think it's a UTI. Yeah, it's a very common issue. And you have to remember, somebody 70 years old already have the kind of mental problem. they may not tell your history right. So sometimes you just have to guess right and rule out the common thing first. You know, like in my office, we have the urine test in the office. We can very quickly test it. UTI, that's it. We go ahead and treat that. Yeah, and then otherwise, you know, you have to go to, you know, like looking for more stuff. Like somebody mentioned MPH, that's a very good one. Yeah, something treatable. Yeah, something treatable. Something can quickly reverse patient's condition is your first step, whatever you try to do. Okay, just for the teaching.
Thank you, Dr. Zhang. Any other questions? Yes, Dr. Darkey.
So as a patient, today's conference is a real promising window into the future. I feel very privileged to be a patient with such amazing care, such a great variety of care. What do you see this, this is a question for you all. What are the obstacles you see for providing such care to everybody? I mean, I feel privileged. How about everybody else? Outside in the world, do they have access to this? And what are the obstacles? Money.
Well, I want to follow Dr. Capizzi's early said is the insurance, you know, the access. Thank you, Dr. Darkey, for that question. And also, I don't want to say this because I'm in the Sutter Health. I have to say, you know, Donna as a managing team, I must say it's Sutter Health, especially with the East Bay, Alta Bates Summit here, has been really supported this type of practice. And earlier I heard about the patients being the advocate. If your brain's still highly function, you can do that. If it's not, and find the neighbors and go adopt, you know. So we all here for adoptions, so we can totally help you. Sometimes many of the patients come to the primary care because they don't want the family make the difficult decision, so they work with the primary care doctor, you know, to make the decision. Back your question, a lot is the finance part. And we do a lot of free work. So we're not like lawyers paid by minutes. Sorry, Craig, I'm not offense you, okay. But we do like our phone call, not even being billable. We have to do those, you know, TV or the visual, but this one, I believe, is going away too. So there's a lot of primary care is a really high burnout. And fortunately, because I have the wonderful team, and Sonam is here too, of a new addition to the integrative medicine. So we want to continue keep the desire and the fire to help our patients. But we will do this together. As a patients, hospitals, you guys have more power. You talk to the insurance company, they listen to you. When I talk to the insurance, they won't even pick up the phone. Hope this is not recorded, okay?
It is. Totally recorded.
Okay, now.
Yeah, so yes, money is a problem. Time. So like you mentioned, there is a high rate of burnout in primary care. There's a high rate of burnout in rehab medicine too. Our patients are often severely disabled. They need a lot of things. And we often remember like I'm going on a tangent maybe, but many of my patients come in and they're critical of their primary care physicians. They've had a stroke and they want to blame somebody. And I understand that. Just as an example, I understand that frustration. Know that in many systems, I mean, primary care doctors, they're given 10 minutes to see you. So know that. I mean, when you come into your doctor and you expect to have an hour, or you expect your 30 questions, if I go to my primary care doctor and I have 30 things on my list, my poor primary care doctor has 10 minutes to see me. So you have to set realistic expectations of your visits. Like we talked about, advocate for yourself, pick an advocate who can advocate for you, and have some grace for your healthcare clinicians and providers who are really trying to do their best. Because that's one of the biggest barriers that I see, is just access to any clinician who can treat the condition and has the time to. That's, in addition to the finances, a barrier, as well as just the social supports, like not having access to paid transport to get to your doctor's office if you are under-resourced or you can't drive, and no one can go to your home to see you there. So that's what I'll end on for access issues.
Thanks. I don't know enough about sort of the inside of the system to know how to answer that question, but I love what I just heard. And, you know, when I first gave my presentation, it was like, it's so great that we're all here. We're investing this time to do this, but how do we leverage that? Like, you know, we're concerned about like everyone getting the treatment that they deserve, or that time with their doctor and the right team. So I guess all we can do as individuals is to continue to connect, and kind of like what you just said was amazing, like give some grace to the healthcare professionals. If you have friends that are complaining, then sort of share the same message. I know it's really hard, how can I help? But like, I guess as humans, we have to connect with each other and try to leverage that message.
Yeah, I don't know what else I'd add. Just I think there's a lot of integrated medical programs going on right now for sure. I know where I was in the West Coast and East Coast, there's a lot of them. They're popping up a lot. You just got to find the best ones that are trained, and unfortunately we are in an entrepreneurial capitalistic medical system, so sometimes out of pockets does get us sometimes different treatments and things you might have to think about. You know, again, I think taking responsibility and just trying to sort that out, I think, you know, yeah. But there's definitely some training, you know, obstacles, you know, the people have to be trained properly, you gotta get the right group together, there's gotta be harmony within the group. So I think there's a lot of variables that play a role for a good, strong team to come together. But it's happening, it's definitely happening. I think there's definitely a big paradigm shift in medicine for that, for integration.
Did you ask about obstacles? We all have obstacles. You got obstacles, we got obstacles. There's perception, there's political, there's economic, there's all of those. So I love all the answers. Everybody gave a solution. So if you have obstacle, come up with a solution. As a group, I mean, how many of this integrative medicine conferences have you been to, just like this? I haven't been to so many. So this is new, and it will have obstacles. Getting the space was an obstacle. Getting all the help and all this is an obstacle. Getting you to be here is an obstacle. You almost couldn't get here. Your flight was delayed, you know. So,
You make it work.
yeah, make it work.
Sure. I want to say take ownership and take action. So as a patient, actually, you have tremendous power. And I strongly recommend when we see a gap of healthcare, take action, such as legislation. And when we have concern about the insurance, like United Health, not just put them on the spot, but we have power to take action, you know. And another way is education. So make sure like we educate the new generation, like physician, pharmacists, dentists, nurses, acupuncture practitioner. So they have this kind of team effort to integrate medicine, don't have the silo. Oh, I'm physician, I'm pharmacist. We're one team. And whenever we make decision, it's not about, oh, this is my territory. No, it's what's best for patient. That's why this is a hurdle we say for integrated medicine, like acupuncture, herbal medicine. We know it's working. Why insurance is not covering? Why it's only covering for senior? Why not, you know, spread, like expand it to all the patient care? It's cost effective, it's working, you know. Another thing I want to point out, there are many free healthcare surveys. Like, you know, I'm from California, North State University. On November 16, we have the 7th annual Capital Region East and West Health Fair. Dr. Feng, you were there. Dr. Matecki, you were there. So we integrate acupuncture, herbal medicine, acupressure with medical service, pharmacy service, dental service, nursing service, and social service. So there are many, many like this. So we can do more based on the need. I just want to say everything is possible when we work together. Thank you.
I would like to, if you can see the patient in a different way. I'm a physical therapist, so I can spend with my patient 30 minutes, where you are saying that a PCP can only spend 10 minutes. We have many patients that they don't have the level of education to understand what you're saying. And in 10 minutes, for the patient that are trying to understand what is high blood pressure, what medication do I have to take, what nutrition do I have to do, is too much. They don't understand. So when the patient come to me and said, what do I have? It's the first time that somebody explained to me what is my issue, because my doctor only spent 10 minutes, and my doctor said, you have to take this, this, and that. We need to have all this lab, but I don't understand what do I have. So the other part that I think is important for the patient is if the physicians can talk to their level, so the patient can understand what do they have. Otherwise, they only are hearing rubbish, and they don't know what is wrong with them. And then they go and said, but why do I have to take this medication, not the other one? What do they mean? So if the physicians can go and speak to the patient at their level, because when the physician only speaks to the patient at the physician level, they're not getting to the patient, and the patient is not going to take the medication or the way how they think, because they're saying, well, this medication is too expensive, so I'm only going to take every 3 days, because maybe that will work for me. I have here so many patients that they do that with the blood pressure medication. It's too expensive. I have to pay $400 because Medicare doesn't cover. So every other day will work. That's not the point. So what I ask, being in the other side where I hear my patients, is if you physicians can really take the time to go to the level of the patient and show them what are you doing and why do they have to take that pill, the blue pill or the pink pill, because that's all that they know sometimes. Thank you.
Thank you, Marcela. Okay.
That's a great question, but I think it's, I'm sorry.
Go ahead.
To respond. 我跟你讲中文的话，一定听不懂，对不对？ So you're talking about communication. Everybody here speaks a certain language, but if I spoke a different language, you're not going to understand me. So you want AI. You want to be able to interpret these languages in a level that 你可以了解 or du kannst verstehen. If I speak a different language, you're a whole different, we are a different language. You learn a different language. With TCM, you learn some language. Every specialty, you have a language. But to now explain it to you, very difficult task you're asking. So I know it's a good question, but at this point, I think you need AI.
And I would also recommend one thing too, again, telling every patient something they don't understand. Again, not to abuse that idea of Googling, but do your research. Absolutely. When I talk to my patients, the first thing I do is explain the pathophysiology of their condition. 100%. I want them to visualize what's wrong, so when I treat it, they can visualize it being corrected. And that actually does have some neurological impact on the brain. There's a hologram that we have based on images we see. So if I see an MRI with 5 herniations in my neck, there's an image in my mind that sees that, and that actually plays a major role in my pain and my ability to move and everything. So I think it's very important to definitely understand your condition. So if someone diagnoses you with a condition, That's great. Can you write that down for me? He doesn't have time. Go home and research it. Research it, get some questions, and then make a follow-up appointment. That's what I think I would do. Because I think it's really important to understand what's going on with you, and that's taking responsibility for your own health, really. I'm serious. Especially nowadays, I think we have to do that. You know, we're all evolving. There's so much in the world. There's so much information. Everyone needs to know, I think, a lot more than we used to, I think, especially now. So we're not all doctors, but, you know, we could Google stuff. We can understand some things and get, you know, find lectures on YouTube and learn things about conditions that we have. And I always think that's important.
I love that. I think that I do like that there's a bit of a responsibility for the physician to speak plain language. When I was in Australia, I didn't go to the doctor, I went to the vet. Well, actually, I'm just kidding. His name was Dr. Vet. But he was a German guy, and he'd been a professor. And what I loved about him is he had the heart of a teacher. And so in his office, he had a whiteboard. And he would always, like, write stuff on the whiteboard. So I really love that. And I feel like, yeah, it's a two-way street, right? Do your research, but also speak clearly and have the heart of a teacher.
Thank you. Yeah, I think the important thing here is that we all have a role, and when we talk about patient-centered and patient-centric, it means bringing them up to a certain level too, or finding an advocate, referring them out as needed. We're out of time. Thank you very much to the panel for joining us and giving us a provocative afternoon. You're welcome. So we're getting ready to wrap up. I just had a couple other introductions to make. Sanam, would you stand up? Sanam Mobin is another one of our faculty lecturers in the residency program, and also a nurse practitioner with the Center for Integrative Medicine now. Welcome. And then I have to invoke privilege of the mic and introduce our granddaughter, Maria Feng, who's just been accepted to acupuncture school. So we think part of the answer to some of the questions here at the end are, each of you need a granddaughter.